Welcome to a discussion of IV admixtures compounding for the modern hospital and home health care pharmacy. This program is provided as the audiovisual component of the Valiteq Aseptic Technique Training and Validation Program and will be presented in 5 parts, consisting of quality assurance theory, engineering controls and laminar airflow theory, barrier controls, aseptic manipulations, and pharmaceutical calculations. An audiovisual study guide is provided as a training aid for taking notes while viewing this presentation. The Valiteq Aseptic Technique Training Manual should then be studied in detail prior to completing the Valiteq written and practical validation exercises. It is recommended that the viewers pause at any time during and at the conclusion of each segment for a review and discussion of the material covered, addressing any questions which may arise during its presentation.
In 2004, the United States Pharmacopoeia, or USP, introduced Chapter number 797 as a mandatory standard for the compounding of sterile preparations, or CSPs. This standard was updated in 2008 to include the latest requirements for institutions and individuals engaged in CSP compounding. USP 797, while yet to be acted upon and incorporated into the pharmacy practice legislation of many states, remains the reasonable and defensible community standard of practice to which practitioners will be legally held. USP 797 was instituted to prevent harm to patients from improperly compounded sterile preparations, identified in recent years as a major source of patient morbidity and mortality. It is an evolving standard that defines the conditions and practices that are required to consistently compound preparations that are sterile, non-pyrogenic, pure, and of the intended strength and quality. USP 797 establishes enforceable standards for facilities, personnel training, knowledge and practices, and equipment in every location where compounding is carried out. While both supervisory and compounding personnel are responsible for becoming familiar with and implementing USP 797, operatives and line personnel should not be permitted to make policies, procedural decisions, or interpretations directly from this standard. Rather, pharmacy administration should initially develop and interpret all specific procedures, facilities, equipment, and documentation necessary for compliance in the form of complete, executable standard operating procedures, or SOPs. While not an exhaustive discussion of USP 797, this program will focus on the newly upgraded aspects of the standard directly affecting operatives and line personnel. The requirements for training, testing, and performance of verification procedures have been enhanced in the most recent revision of the standard. The use of sterile, powder-free gloves and sterile alcohol as a surface disinfectant are now mandated. Also required is the periodic, ongoing microbial monitoring of the operative's gloved fingertips and work surfaces. These procedures include a requirement for an initial 3-replicate demonstration of competency in the aseptic donning of sterile gloves prior to performing any compounding, and 1 replicate annually thereafter. In addition to direct observation of the complete verification exercise by the CSP supervisor or preceptor, the glove tips must also be tested for microbial contamination with a surface contact plate and must exhibit zero colony forming units, or CFUs, scientifically establishing the sterile gloving competency of the candidate. The gloves should be discarded and replaced after any glove fingertips are sampled. In addition to the periodic microbial monitoring of all operatives' glove tips and critical environmental surfaces, active aerobiological monitoring of the anteroom and critical core environments is also required by USP 797. This testing is useful in determining the effectiveness and necessary frequency of these new mandatory disinfection procedures, designed to maintain in-process gloves, critical surfaces, and facility air quality in a near-sterile condition. The new revision also includes requirements for CSP pre-release checks, regular environmental monitoring of the CSP process, and comprehensive documentation of quality assurance procedures and data. All USP 797 mandated microbial monitoring of the CSP facilities and personnel should be carried out, documented, and trended using the correct tools, procedures, and software. This trending should be used in carrying out the constant quality improvement, or CQI, of the CSP process and facilities. It is imperative that all compounding personnel be selected on the basis of their aptitude for this critical work, as well as their ability to become team players, to exhibit unvarying supportive attitudes, and enthusiastically cooperate with the purposes of USP 797. The institutional objective: assure continuation of the quality guaranteed by the manufacturers of parenteral drugs and solutions, which are compounded by the clinical, hospital, and home health care pharmacy. IV admixtures provided to the patient in institutional and home care settings are the product of a complex system of numerous storage, compounding, and administration functions. In the compounding phase, sterile drugs and components are aseptically combined and made ready for administration to the patient. This must be accomplished without any compromise of the nature and quality of the finished IV admixture by personnel responsible for its compounding and delivery. The body's natural route of absorption of nutrients and drugs is through the epithelium of the skin, the lungs, the gut, and the heavily vascularized epithelium of the nasal, sublingual, and rectal areas. Drugs administered by these routes may be deactivated or their therapeutic value limited by oxidation, poor absorption, or digestive breakdown. These limitations may be overcome by injection of drugs directly into the body with a hypodermic needle. This method of administration is known as parenteral route administration. The most direct parenteral route is the intravenous route, which immediately and irreversibly spreads the drug throughout the body. The same characteristics that make IV therapy useful can also pose risks to the patient. Contaminants introduced along with the drug will also spread quickly, bypassing the body's natural defense systems, causing intravascular infection, life-threatening pyrogenic response, or dangerous occlusion of the microcirculation in the brain and vital organs. Absolute control is therefore required to protect the integrity of parenteral products. The natural environment contains numerous contamination sources and is laden with particulate matter, microorganisms, allergens, pyrogens, and drug residues. Particulate matter introduced by the IV route may result in severe complications, such as occlusion of the peripheral blood vessels, causing clouded vision and neurological complications. Particulate matter consists of general environmental particles of smoke, dust, hair, fragments of glass produced when ampules are opened, and small cores of septa material which may be punched out when the hypodermic needle penetrates septa and additive ports. Microorganisms introduced directly into the bloodstream may cause a serious intravascular infection and may in some cases produce a fatal bacteremia. Microorganisms include bacteria, fungi, viruses, and certain parasites which may be airborne, waterborne, or surface-borne, and are abundant in human hair, skin, and saliva. Allergens include pollen, dust, insect and animal dander, molds, and other materials. Allergic responses to latex are becoming increasingly common in the hospital environment. Pyrogens are fever-causing residues of dead and decomposed microorganisms. These substances can cause a life-threatening pyrogenic response in patients inadvertently receiving them in IV solutions. Drug residues are a threat to any patient for whom such drugs are not intended. In industry, removal of drug residues is a normal part of sanitizing the manufacturing environment and is referred to as line clearance. The two main systems of demonstrating product quality in any production scenario are quality control and quality assurance. Quality control is based upon the successful pre-release testing of products to prove their compliance with manufacturing specifications. This system is known as product auditing and is impractical on the pharmacy level. IV solutions produced would require up to a 2-week quarantine to prove compliance through actual testing of the product. The immediate demand for IV medications to be used within hours or even minutes of compounding precludes such a lengthy quarantine. The quality assurance approach to product release is indirect. It begins with the proof of the production system's ability to consistently produce good products that meet specifications. This is known as validation. Validation is usually accomplished by performing a simulation of the actual process, using microbiologic growth media in place of the product. Validation proves the capability of the production system, but this alone is not enough to demonstrate the acceptability of the product. Quality assurance also requires proof that the validated system is continuing to operate as it should. For this reason, the validation is combined with periodic monitoring of the system to assure that it continues to operate in accordance with validation conditions. Using quality assurance, validation of the work environment, the process, and personnel skills is initially carried out, with ongoing monitoring of process parameters to assure continuing compliance. This system is known as process auditing and is based upon the assumption that the product is acceptable if the process and personnel have been validated, and regular monitoring detects no deterioration of operating conditions.
In today's very crowded pharmacy curriculum, with its understandable emphasis on clinical subjects, little, if any, time can be allotted to quality assurance topics dealing with the dispensing of injectable products. However, it is imperative that each hospital pharmacy establish a robust, consistent, overall quality assurance program. Too often the programs that do exist are not the kind they should be. Not because practitioners don't want to do it right, but because they don't have the necessary skill sets. I've seen hospital pharmacies at large institutions where there are many satellites. They allow each satellite to develop their own operating procedures and their own forms, so that there is even variation within a single hospital. This makes it very difficult to achieve the consistency required for the total quality assurance needed to provide the best standards possible. When one looks at the overall systems, as I have in several instances, one cannot track and document events and products to the degree you should be able to.
Because quality assurance release of product is not based upon actual proof of product quality, pharmacy IV admixtures programs incorporate several overlapping strategies to provide the highest level of assurance. These include engineering controls to reduce contamination potential, barrier controls to reduce contamination transfer, and personnel controls to prevent contamination events.
As an IV admixtures specialist, you will be asked to perform a validation exercise which demonstrates your ability to properly use your institution's engineering controls, personal barrier controls, and aseptic manipulations to accurately compound contamination-free product. During this validation, you will be asked to use sterile microbiologic growth media to simulate the proper compounding process. While you're conducting this simulation, you will be observed by your pharmacy preceptor for compliance with your institution's policies and procedures. The simulated products you produce will be incubated for the required time, after which they will be observed for clarity, indicating that you have properly compounded the products without introducing any viable contaminants. If any of the products become turbid, this will indicate that you have introduced viable contamination into the product at some point during the simulated process. You will need to repeat the exercise following the necessary retraining. From time to time, you will be asked to repeat this exercise for revalidation based upon the requirements of your institutional policies. Continuous ongoing monitoring will be conducted by your pharmacy preceptor or supervisor and will include regular observation of your performance. Along with observation, the supervisor will verify that the necessary documentation, including the refrigerator and freezer temperature logs, the hood cleaning logs, and equipment and compounder calibration records, has been properly completed.
Because the documentation of a quality assurance system is the justification for the ongoing release of pharmacy products, the importance of proper documentation of all aspects of a QA program cannot be overstated. A standing rule in industry is that if you didn't write it down, you didn't do it. There are no excuses. Thus, the integrity of pharmacy-produced products can be effectively demonstrated through quality assurance using process auditing procedures.
The best guarantee that a product will conform to what is stated on its label is strict adherence by conscientious personnel to good compounding procedures. In order to minimize product contamination, these compounding procedures must be carried out within a carefully controlled environment. This environment is produced by mechanical air cleaning devices that are known as engineering controls. As a member of the IV admixture team, you should become familiar with the different types of engineering controls that are used to support your aseptic processing. Only through complete understanding of how each device operates will you be able to assure that your compounding process is under control and maximize the safety of all admixtures you produce.
Engineering controls are used to provide a work environment that is virtually free of airborne contaminants and is easy to clean and disinfect. Engineering controls are divided into two groups, primary and secondary engineering controls.
Primary engineering controls are used to produce a critical work zone with sterile supply air where aseptic manipulations are performed. Secondary engineering controls are then used to create a buffer zone between the critical work zone and the general outside environment. The two primary engineering controls employed in the IV pharmacy are the Laminar Flow Clean Bench, or LFCB, and the Laminar Flow Biological Safety Cabinet, or BSC. These devices are commonly referred to as hoods. A third type of primary engineering control, or PEC, recently introduced as an additional option in the compounding of CSPs, is the Compounding Aseptic Isolator, or CAI. A negative pressure version of the CAI is designed for use with hazardous drugs and is called a Compounding Aseptic Containment Isolator, or CACI. The selection, installation, certification, and operation of the new CAI concept are covered more fully in a separate lab safety DVD program, Compounding Aseptic Isolators, available directly from Valiteq. In operational terms, the unidirectional airflow CAI functions in a manner similar to the Biological Safety Cabinet, or BSC, with similar airflow patterns. Compounding personnel must learn and unvaryingly follow the proper procedures for introducing materials and removing finished preparations and waste materials from this new type of unit. It is important to remember that numerous contaminants may easily be introduced into the CAI along with non-sterile supplies. These contaminants may become more difficult to eliminate due to the relative inaccessibility of the CAI's core interior and the resulting difficulty in properly cleaning this design. Also, if flawless containment technique is not followed in the CACI, the hazardous drugs manipulated may contaminate the outer surfaces of final containers and ultimately be transferred to the environment. The key component common to all three types of engineering controls is the high-efficiency particulate air filter, or HEPA filter. The HEPA filter is rated to be at least 99.97% efficient. This means that at its point of least efficiency, The HEPA filter is capable of trapping and retaining a minimum of 999,700 of every million particles greater or smaller than 0.3 microns. To put this into perspective, a human hair is 50 to 200 microns in diameter. Microbes and other fine atmospheric contaminants are 0.2 to 1 micron in diameter. The HEPA filter therefore produces exceptionally clean air within the critical work zone of the laminar flow device. The HEPA filter is normally constructed of a fiberboard frame with continuous neoprene gasketing. The filter medium is an extremely fine-pored paper-like material made of borosilicate glass, which is pleated around aluminum separators to greatly increase the filtration area. This medium is extremely delicate and is very easily damaged by the slightest touch, which can drive the separators through the rear pleats, causing a considerable leak. Leakage caused in this manner may not become evident until a filtration performance test is performed. An important characteristic of the HEPA filter is that air issuing directly from the filter face flows at a uniform speed and in a uniform direction, providing a cohesive wash of clean air which prevents the influx of contaminated air from the outside. Uninterrupted clean air issuing directly from the HEPA filter face is an important concept known as first air. All critical sites and pathways must be placed in first air flow. It is most important to remember that the HEPA filter only supplies clean air. It does not remove contamination which exists on the internal hood surfaces or from objects placed within the hood. Another important characteristic of the HEPA filter is the relatively low speed of air movement. Air exiting the opening of an LFCB is easily disrupted by erratic movements close to the hood, by talking or laughing at the hood, by room ventilation systems, and by rapid hand movements within the work zone. Remember, all critical sites and pathways must be maintained in the flow of first air. A critical site or pathway is any location or route through which the product may become directly exposed to contaminants. Examples of critical sites and pathways are septa, needles, filter straws, spikes, open ampules, bag and bottle connections, and compounder connections. As long as the critical site remains within the undisturbed first air, the operator can be assured that no airborne contaminants have been introduced. If the airflow from the HEPA filter makes contact with any object before coming into contact with a critical site or pathway, it is no longer possible to be certain that only clean air is reaching the critical site. Make certain that no obstruction blocks the flow of first air to any of these critical sites. The LFCB is a self-contained unit consisting of an air handling motor and blower which push air through a supply HEPA filter. It is designed to provide protection of the product only. In a horizontal flow clean bench, the HEPA filter becomes the entire back wall of the enclosure. Clean air flows directly outward towards the front of the cabinet. A vertical flow clean bench is similar, except that the HEPA filter is located at the top of the enclosure, and air flows downward toward the work surface before turning and exiting out the front of the unit. Remember that first air in a vertical flow clean bench will be moving from above, rather than from the back of the unit. Also, please note that a VFCB is not a biological safety cabinet. Our demonstrations will be conducted in a horizontal flow clean bench.
Personnel who use laminar flow hoods are likely to feel secure about the aseptic procedures that are carried out inside the hood. The physical presence of the hood and the sound of the air passing across the bacterial retentive filter provides a psychological assurance that the environment inside the hood is safe and the admixture is protected from bacterial contamination. Thus, personnel who prepare IV admixtures are likely to believe that contamination will not occur if an admixture is prepared inside a laminar flow hood. However, contamination of IV admixtures prepared inside a hood can and does occur.
Because the flow of first air in an LFCB is relatively slow and easily disrupted, there are several factors that may cause disruption of first air flow, leading to contamination. The three principal contamination models in an LFCB are downstream contamination, backwash contamination, and cross-stream contamination. Downstream contamination may occur whenever a critical site is placed downstream from another object, blocking the flow of first air from the HEPA filter. Backwash contamination may occur when room air is allowed to wash back into the LFCB. Several conditions may cause backwash contamination, such as room ventilation or air conditioners which produce air currents counter to the flow of air from the LFCB. Movements of personnel in close proximity to the LFCB, the arms of the operator extending into the LFCB, and objects placed too near the open end of the LFCB. An object placed into the LFCB creates a zone of confusion, which extends at least 3 object diameters downstream from the object toward the open end of the LFCB, provided there is laminar flow on both sides of the object. If the object is placed against or close to the side walls of the LFCB, this zone of confusion may increase to 6 diameters, because laminar flow occurs on only one side of the object. It should always be assumed that air in the front 6 inches in from the open end of the LFCB is contaminated by backwash contamination. All items in operation should be located well behind an imaginary 6-inch line, with all objects sufficiently separated to assure good airflow around them. Cross-stream contamination occurs when disturbances created in the airstream cause air currents to flow crosswise in the LFCB, carrying contamination from one object to another. Cross-stream contamination may occur if items are placed too near each other, or if the operator uses rapid or disruptive hand movements within the LFCB. Methods of minimizing the potential for these types of contamination will be discussed in the aseptic manipulation section of this program. The BSC is also a self-contained unit having an air handling motor and blower system, and both supply and exhaust HEPA filters. The BSC is designed to provide protection for the user, as well as the product and environment. The BSC is normally used in pharmacy to compound and prepare hazardous substances, such as cytotoxic agents, vaccines, antibiotics, and antivirals. The design of the BSC is complex and requires careful balancing to assure proper operation. Several different BSC designs provide varying degrees of protection. However, the design most common to pharmacy operations is the Class II Type A B3 cabinet. In both the Type A and B3 configurations, 70% of the internal airflow is recirculated through the supply HEPA filter, as 30% of the internal air is vented to the outside through the exhaust HEPA filter. This 30% exhaust is replaced at the sash with an equal amount of inflowing air. This is known as makeup air, which is needed to produce the required inflow velocities to the unit for containment of hazardous compounds. The Type A configuration has no exhaust interconnection to the outside and vents through the exhaust HEPA filter directly into the room area. The Type A BSC is not suitable for any agent which produces hazardous fumes or vapors, such as vesicant gases. In the B3 configuration, the unit is connected to an outside exhaust by negative demand ducting. The B3 design is suitable for use with small amounts of hazardous vapors, provided negative pressure is maintained in the exhaust duct. In a BSC, clean air flows downward from the supply HEPA filter, which is located above the work surface. As it approaches the work surface, the air splits. With half of the air flowing back through the return grills at the rear of the cabinet. And the other half flowing forward to the front return grill. The air flowing toward the front of the cabinet is prevented from carrying contaminants out of the cabinet when it combines with the makeup air flowing in through the front opening to replace air exhausted through the exhaust HEPA filter at the top of the cabinet. This inward flowing makeup air is actually contaminated room air, which is prevented from flowing onto the critical work surface by the forward flowing supply air. It is critical that these two airflows be carefully balanced by proper adjustment of the window sash at the marked sash operating height, which is normally 8 inches. The BSC must be set to the design sash height without variation. The BSC must never be operated with the sash open, even during cleaning, because opening the sash will reduce the inflow velocities, compromising proper containment. Neither should the sash be lowered to just above the hands. Never operate the BSC with the sash fully closed. This will cause overheating of the air handler, resulting in electrical problems with the unit. Both makeup air and the forward-flowing supply air pass downward through the front grille and under the work tray before returning to the rear chase to the air handler. The under tray area can be expected to be contaminated with both hazardous materials and atmospheric contaminants. This area must be kept clean by thorough, routine sanitizing at the beginning and completion of each shift, and immediately whenever spills occur. All sanitizing operations should be logged on the hood cleaning log. As with the LFCB, several design aspects of the BSC must be observed to prevent contamination of the personnel, product, and the environment. When arranging objects in the BSC, remember that the first air is provided from above the work surface. Be sure that first air to the product is not disrupted, and that a clear zone remains for conducting manipulations. Remember also that the supply air splits as it approaches the work surface at a location known as the smoke split. A zone of confusion exists in this area, and no critical sites or pathways should be located directly within this zone. Also, under no circumstances should any objects be placed on either air return grill, and no operations should be conducted within 3 inches of the front grill. The operator's arms extending into the cabinet create a disruption of the protective air stream. To minimize this disruption, hands should be inserted and removed in a slow, perpendicular motion, and rapid and erratic movements avoided. As with the LFCB, the airflow within the BSC is relatively slow and easily disrupted. Of special concern is air venting under pressure from vials, needles, and syringes. This air is heavily contaminated and is moving under much greater pressure and speed than the protective air curtain, and may easily penetrate the air curtain and contaminate the operator and the environment. Although the BSC does provide some protection and containment of hazardous materials, recent studies have detected surface contamination in pharmacy compounding areas and patient administration areas outside the BSC, as well as the presence of antineoplastic agents in urine samples collected from pharmacists, technicians, and nurses using BSCs and gloves as the minimum level of protection. There are several reasons for this, most related to inadequate cleaning of the cabinet and careless technique. Some of the contaminants are carried into the general area on gloves, restocked supplies, and product that is contaminated by sloppy technique. This course is not intended to be a complete training program in chemotherapeutic agent compounding. However, a number of precautions are mentioned throughout the program and should be strictly adhered to. All practitioners involved in compounding of hazardous materials should undergo rigorous training. This should include a validation exercise designed to verify their ability to compound aseptically without transferring contaminants to the general environment. Secondary engineering control should be employed to provide a buffer zone as an essential controlled interface between the hoods and the outside environment. A gowning anteroom or designated area should be included between the buffer zone and the outside environment, where preparation and staging of all working materials, gowning and scrubbing, and degowning at the conclusion of operations may be carried out. The level of secondary engineering control varies from institution to institution. Ideally, the buffer zone will be supplied with HEPA-filtered air through supply terminals with sufficient volume to meet design cleanliness requirements under operational conditions. The buffer zone should be under positive flow or pressure to the gowning anteroom, which is in turn under positive flow or pressure to the outside environment. The buffer zone may have its own HEPA-filtered air supply. This arrangement causes facility air to flow outward from cleaner to dirtier areas, preventing the ingress of atmospheric contamination. The constant recirculation of buffer zone air through the LFCB, known as air broom effect, may contribute significantly to air cleanliness within the buffer zone. However, pressurization of the buffer zone can only be produced by supplying more air to the room than is taken out. Secondary engineering controls provide only clean air, and contaminants introduced by operators on clothing and materials must be controlled in order to maintain cleanliness. Routine sanitizing procedures should be defined, carried out, and documented in the housekeeping or sanitizing log. Whenever possible, low-lint wipes and cleaning materials should be used. All reusable cleaning equipment should be dedicated for clean room use only and must be sanitized after each use and properly stored. Professional barrier controls are used to isolate and protect workers from the adverse effects of their work environments. In medical procedures and in IV pharmacy, barrier controls are also used to protect patients and products by preventing the transfer of contaminants to critical sites or pathways. Barrier controls consist of gowns or lab coats, hair cover, masks and beard cover as necessary, shoe covers, and gloves. Protective goggles are required for the compounding of hazardous materials. The gown or lab coat is used to minimize the shedding of both viable microorganisms and non-viable particles from the operator's clothing. When compounding hazardous substances, the gown used should also protect the operator and should be resistant to penetration by the products manipulated. It should provide elastic cuffs to limit exposure of the operator's arms and closure at the back of the gown. Disposable gowns are preferable. If non-disposable gowns are used, they must be handled carefully and laundered as contaminated materials. Hair cover prevents shedding of hair, microorganisms, skin particles, and dander from the operator into the compounding area. The elastic closure should contact the skin below the hairline with all hair contained within the hair cover. The cover must remain intact. No tearing or opening of the cover for heat relief or for any other purpose is permitted. Remember, hair cover is not flattering, and no attempt to look good in hair cover should ever be made. Breath masks offer product protection by providing a physical barrier for absorption of sputum and help prevent it from entering the work zone when the operator inadvertently speaks or coughs. Droplets of saliva produced during speech, coughing, or sneezing can reach velocities of 5 to 25 feet per second, which can easily deposit them directly onto critical sites. For obvious reasons, the use of masks is especially important for personnel experiencing allergies. Personnel with upper respiratory infections should not compound IV products. The mask should be comfortable and be fitted properly to the wearer's face, using proper snugness and form-fitting nose closure at the bridge of the nose, just beneath the eyes. The mask should be used only once and disposed of immediately following use. It should not be reused or left lying around as a concentrated source of microbiologic contamination. Shoe covers isolate the soles and surfaces of street shoes and prevent the tracking of numerous outside contaminants into the buffer area. Because the most common source of IV admixtures contamination is touch, gloves are an essential barrier control. As with all skin, the bare hands contain two types of microbial contamination: transient flora and resident flora. Transient flora, the microorganisms which are eradicated with hand washing, represent only 15% of the total contamination burden on the skin. The resident flora constitute 85% of this burden and reside deep in the follicles, pores, and sebaceous glands. These flora are not affected by even the most thorough hand washing and begin to replenish skin surface contamination minutes after washing, until very soon the contamination burden returns to the same levels which existed before washing. Regardless of the degree to which they are washed or disinfected, the bare hands will, therefore, retain at least 85% of their total microbial contamination. While not sterile, gloves do provide a renewable bacteriostatic barrier as compared to the bare hands, and are used to completely contain microorganisms and skin particles which shed profusely from the hands during the compounding process. This is easily illustrated by a comparison of contamination levels present on the gloved hand versus the bare hand. In this demonstration, both hands were kept in first air for 30 minutes after washing. The gloved and prepared hand on the right and the washed bare hand on the left are placed onto two Petri dishes containing a microbiologic growth medium. Following incubation, it becomes clear that the contamination burden on the bare hand has increased to many times greater than that of the gloved hand. Gloves act as a barrier to this type of contamination fallout from the hands, and should therefore be donned and prepared properly prior to entering the compounding environment.
Are gloves necessary? Yes. There are three arguments used by those individuals who do not want to use gloves. First is latex allergy. Second is reduced finger dexterity and tactile feel, which can lead to lower productivity. And three, quote, I am careful and never touch aseptic surfaces, unquote. All of these reasons are flawed. Latex allergies are serious and widespread, but there are a number of latex-free gloves in the marketplace today. Yes, you may need to modify your procedures and slow down some, at least at first. But skin constantly gives off or attracts clouds of particles, dust, and skin fragments, which you can actually see when viewed with special backlighting. Washing hands is important, but can result in more particles and bacteria being brought to the skin surface.
Initially, the hands should be washed and the fingernails cleaned with a mild soap. They should be rinsed thoroughly and dried completely using a clean towel. The gloves should fit each operator properly to assure complete dexterity. Ill-fitting gloves will interfere with good manipulative technique. Gloves should not be considered to be sterile during the compounding process, even when sterile surgeon's gloves are initially used, because they become contaminated as soon as non-sterile vials, bags, and other working materials are handled. The following procedure should be carried out during garbing. Upon entering the ante area, personnel are required to scrub the hands and arms, allowing them to thoroughly dry. All gowning except gloves should then be donned prior to entry into the buffer area where the PECs are located. Another updated USP 797 requirement is the use of sterile alcohol as a periodic disinfectant for gloves and critical work surfaces. Because alcohol alone is not a sterilant and may itself become contaminated, the use of sterile alcohol assures a sterile disinfectant baseline condition, thus preventing the introduction of residual spore-forming or other resistant microorganisms to critical surfaces during its application. Upon entering the buffer area, the hands are to be carefully resanitized with a waterless, alcohol-based surgical hand scrub, such as chlorhexidine, prior to aseptically donning sterile gloves. In the buffer area, stage the sterile gloves for use. While opening the glove package to access the gloves, take care not to touch the gloves, marked as either left or right, while the sterile packaging is being unfurled. Aseptically open the sterile glove container in accord with the manufacturer's directions. Each glove cuff will be partially folded back to reveal a portion of its inner surface, which may be touched. However, the sterile glove palm and finger areas must never be touched during garbing. Insert the fingertips into the correct glove, while carefully grasping its folded inner surface with the other hand, and pull the glove on completely. Don the second glove in the same way, taking care not to contaminate the fingers or palm of the opposite hand. Aseptically place the glove cuffs over the gown cuffs, assuring only sterile surfaces touch the sterile outer sides of the gloves. Because the originally sterile gloves will not remain so following contact with vials, syringe wrappers, and other non-sterile compounding materials, frequent resanitizing of the gloves is recommended immediately after loading compounding materials into the PEC, periodically during compounding, and whenever the operative leaves the critical aseptic field for any reason. This is accomplished by applying sterile alcohol directly to the glove surfaces within the PEC critical work zone while remaining within the first air. Briskly rub the hands together for a few seconds to evenly distribute the disinfectant, allowing it to dry completely. Remember, complete drying of the alcohol is necessary to achieve the maximum germicidal effects of plasmolysis, the major lethal action of alcohol. Also, please note that even such conscientious application of the sterile alcohol will not re-sterilize the glove and work surfaces, but rather will reasonably assure a renewable bacteriostatic barrier over time to minimize the accretion and transfer of microbial contamination to the sterile preparation. When gloves are used as a protective barrier for the operator during the compounding of hazardous materials, double gloving should be employed, and a special technique should be used in gloving and degloving. There are several reasons for using two pairs of gloves, regardless of their composition. First, testing has revealed that gloves may come from the manufacturer with up to a 4% leakage rate. Second, all glove materials are penetrable by some CYTAs over time. The outer pair, at least, should be replaced every 15 to 20 minutes, or whenever you know they have become contaminated. Third, gloves may tear, and a second pair underneath provides an additional safety margin. Finally, wearing an inner pair of gloves facilitates better spill handling, because overtly contaminated, possibly dripping outer gloves can be removed immediately and replaced without exposing the bare skin. In this procedure, the glove should be donned so that the first pair lies inside and under the sleeve cuff. The second pair should then be placed over the cuff. The outer pair of gloves should be removed whenever the hands are removed from the BSC to avoid transferring hazardous materials to the environment. Deglove the outer pair by grasping the outside of the first glove, near the cuff, and pulling the glove off inside out, reducing it to a ball in the opposite hand. Remove the second outer glove by slipping the fingers of the other inner gloved hand under the cuff and pulling the remaining outer glove down and over the first glove, taking care not to contaminate either inner glove. Secure the outer gloves inside out, with all contamination inside the ball, and dispose of in the BSC internal waste container. Remove the hands from the BSC. Don a fresh pair of outer gloves prior to recommencing compounding and disinfect the gloves with 70% isopropyl alcohol. If compounding is completed, the gown should be removed next. It must be assumed that sleeves of gowns become contaminated with hazardous substances during compounding. For this reason, gowns worn during compounding of cytotoxic agents should be removed properly and not be reused after removal. This is done by grasping the outer surface of the opposite back shoulder areas and pulling the gown forward over the sleeve. Secure the sleeve by grasping it through the inverted gown back and remove the hand. Repeat the process for the other side. The gown will now be inside out, with the sleeves contained, and may be gently rolled into a ball for disposal. After degowning, remove the inner pair of gloves in the same manner as the outer pair. Remaining items of gowning can now be removed. All gowning should be placed in a chemo waste container. Remember, no gloves or gowns used in compounding hazardous substances should ever be reused after degowning. All gowns, lab coats, and other barrier items should be clean and should not be worn outside the compounding area. This will eliminate the potential for transfer of drug residues to the institutional environment and prevent environmental contamination of barriers which may, in turn, be introduced into the buffer zone and critical aseptic core.
If your tools, for example, your gloves, your gowns, your face masks are not properly put in place, or if you don't use them at all, everything that you may be doing could be for naught, because you're introducing another variable. You're introducing a potential organism. You're introducing a potential particulate. Either one of these items could be fatal. Either one of these items could contribute to something that cannot be discerned. And again, I'm emphasizing that the final end user is a person. You know, there's nothing you can do. You know, once that item has been introduced, it can contribute to a particular person's problem, or if it's a multiple operation, you can continue down the road and contribute to a number of people.
A pharmacy quality assurance program must always encompass several elements, which include engineering and facility control, packaging and label control, laboratory controls, and personnel controls. Of these, the most critical is personnel control. A break in aseptic technique by pharmacy personnel can affect many patients. It is essential that personnel have the knowledge and the skills that are required to consistently produce quality injectable products.
Aseptic manipulations encompass the entire body of activities performed by personnel to produce IV admixtures and are divided into 3 stages: preparation, compounding, and cleanup and product release. Preparation for compounding begins in the anteroom or gowning area with the staging of all compound materials. All IV bags, vials, syringes, and other working materials should be removed from bulk cartons in the anteroom or gowning area prior to introduction into the buffer zone. Any gross contamination present on these materials should be removed by wiping with a low-lint wipe moistened with 70% isopropanol. Avoid excessive moisture, which may damage labels or syringe wrappers. All working materials should then be transferred to the buffer zone for compounding or short-term storage in plastic bins. Next, gowning of admixtures personnel should take place. Operators should remove all jewelry from the hands and wrists. Dangling necklaces and earrings should also be removed, and no makeup or nail polish should be worn. This will prevent the transfer of particulates to the buffer zone and critical sites. Personnel should thoroughly wash hands, arms, and clean the fingernails with mild soap prior to donning the required apparel.
At the beginning of the shift, The operator should check all data logs, such as refrigerator and freezer temperature, the hood cleaning logs, and any other data entry records, verifying completeness and making all entries as required. Any out-of-limits condition should be reported immediately to supervisory personnel. Proper operation of the hood should now be verified. If the hoods have not been operating, they should be turned on and allowed to run for at least 20 minutes, allowing them to stabilize. The performance certification of the hood should now be verified by checking that a sticker referencing a test report and expiration date for the current period is affixed to the service panel. Many LFCBs and BSCs are equipped with a magnehelic pressure gauge. While this gauge cannot be used to assure proper performance of the hood, it can be used to verify that the fan is operating and that no radical change in performance has occurred since the last performance test. It is recommended that, following a successful performance test of the unit, the tester mark the face of the gauge to indicate the acceptable operational range. Manufacturers of the most modern BSC designs incorporate CPU-driven thermistor technology, which controls and reads out actual inflow and downflow values. This readout does assure operation at the proper velocity profile for the unit. Have your certifier record the acceptable performance ranges on the certification sticker. The operator should verify that the required exhaust and downflow values are present. Many biological safety cabinets are also equipped with alarms. If the alarm is sounding, verify that the sash is at the correct operating height. If the pressure monitoring equipment indicates operation outside the acceptable range, or the alarm sounds when the sash is properly adjusted, call a qualified professional to determine the cause of the problem and make the necessary repairs and adjustments. Under no circumstances whatsoever should the user attempt to repair or adjust any component of any laminar airflow device. Regardless of how the hoods appear, they must be cleaned and disinfected prior to each use. Many drug residues are not alcohol soluble. Neither does alcohol alone provide a complete spectrum of antimicrobial action. Therefore, a high pH, low residuing water-based disinfectant cleaner should be used prior to disinfecting with 70% isopropyl alcohol to both clean and disinfect the critical work surfaces. It is important to understand the method by which alcohol destroys microbiologic agents, because improper use of alcohol will not result in the desired disinfection of critical work surfaces. Also remember, alcohol is only a disinfectant. It is not a sterilant. Even a thoroughly cleaned and disinfected work surface may still contain viable microorganisms. To work effectively, alcohol must first be absorbed by microorganisms, then allowed to dry completely. It is only when the alcohol dries that plasmolysis, or cell membrane destruction, occurs and the organism is destroyed. Alcohol on the surface of a septum may simply become a vehicle for the transfer of organisms through the septum and into the vial, where the drug solution may prevent the dehydration necessary to kill the organism. A combination of 70% alcohol and 30% water is the optimum concentration for antimicrobial activity because it provides the ideal combination of strength and exposure time. Higher concentrations of alcohol may evaporate too quickly to sufficiently penetrate the organism, while lower concentrations may not evaporate sufficiently to cause plasmolysis. Either ethyl or isopropyl alcohol may be used. Isopropyl alcohol is most common and is also called isopropanol or IPA. The proper method of cleaning a horizontal LFCB should begin at the top inner surface, which usually contains the lighting panel, to prevent cleaning solutions from dripping onto previously cleaned surfaces. Using care not to touch the HEPA filter, begin at the rear of the hood, using strokes parallel to the HEPA filter and gradually work your way to the front of the unit. Next, clean the IV pole and hooks. The sides of the clean bench should be cleaned with vertical, top-to-bottom strokes, again working your way from the rear to the front of the unit. Finally, the work surface should be cleaned using a pattern similar to that used to clean the top of the unit. Do not use back-to-front strokes, which will carry contaminants from the front of the hood back to the rear. No attempt should ever be made to clean the HEPA filter. Also, the protective screen should not be cleaned in place. If the LFCB is a modern design with an easily removed screen, it may be removed, cleaned, and carefully replaced. Do not attempt to routinely clean screens which are not designed to be easily removed, or damage to the HEPA filter is likely to occur. If proper manipulative technique is employed, the protective screen should not require frequent cleaning. Following cleaning, 70% alcohol should be applied and allowed to dry completely without wiping. Cleaning a BSC in which hazardous materials are handled requires special gowning and disposal of cleaning materials as hazardous waste. Prior to commencing work, be sure a spill kit is immediately available to the operator. Copies of the spill and exposure policies and all necessary material safety data sheets should be reviewed and completely understood by the operator prior to compounding activities. All operators must be completely familiar with the substances which they are to compound and understand the emergency procedures required for each individual substance before compounding. Because time is of the essence in an emergency, it may be too late to familiarize yourself with and prepare for the specific emergency actions required after a spill or exposure has occurred. Also, emergency room personnel may not be familiar with the substances you compound. Gown as usual for hazardous materials compounding, but add a third pair of heavyweight disposable gloves. The first pair of gloves should be under the gown cuff, and the second and third pair over it. Stage the cleaning materials close to your clean supply hand, including a sealable chemo waste container which will fit in the hood and is large enough to accommodate cleaning waste, a chemo disposal bag large enough to contain the waste container, 2 chemo-resistant mats, or 1 mat cut in half, 1 additional pair of outer gloves, at least 10 low-linting disposable wipes, a high pH low-residuing water-based cleaner, and 70% IPA for final disinfection. A large chemo disposal container should be available immediately outside the BSC. The hood must be running during cleaning procedures because you will be disturbing any chemo residues present, and proper inflow velocities are required for your protection. Do not open the sash above the marked height. Maintain the cleanliness of the clean supply hand for handling the cleaner and alcohol spray, using the dominant hand for wiping. Place the waste container on a chemo mat at one side of the work surface. Spray the outer front lip and the top of the front grill with the cleaner and wipe, starting at the bottom of the lip, working up and in. Because the HEPA filter is located at the top of the work area, cleaning the interior surfaces should begin at the top of the back wall, again taking care to avoid touching the HEPA filter. Using strokes parallel to the HEPA filter, work your way from the top to the bottom of the back wall. Next, clean the IV pole and hooks, and then the side walls of the cabinet in the same manner as the LFCB. Clean the top of the work surface and back grill if present. When all of the work surface except the area where the waste container is sitting has been cleaned, move the waste container to a cleaned area and pick up the mat by pinching it near the middle so that the dirty underside is folded inside, and dispose of it in the waste container. Clean the remainder of the work surface. Clean the inside of the view screen. Pick up the waste container with the clean hand and lift the tray far enough to access the under tray area with the dirty hand. Place the waste container on the front grill and place a new chemo mat in the under tray. Set the waste container on the mat. Lift the work tray and prop it against the back wall of the cabinet. Change the outer pair of gloves, which may have become contaminated while handling the work tray. And clean the back side of the work tray, again keeping one hand clean and using the other to wipe. In older model hoods, there is no paper catch screen to prevent the aspiration of paper towels and other cleaning materials into the air handler. Be careful not to allow loose towels or other materials to be sucked into the air handler. Modern designs do have a paper catch, which must be periodically cleaned to prevent the obstruction of airflow. Next, clean the back of the front grill and prop it against the work tray. Thoroughly clean the under tray area. When all of the under tray except the place where the waste container is sitting has been cleaned, move it to a clean area and dispose of the mat as before. Clean the area where the container was sitting. Remove the outermost pair of gloves and place them in the waste container. Seal the container and place it in the bag, which should then be sealed and disposed of in the chemo disposal container outside the hood. Disinfect the under tray area and the backside of the work tray and grills. Return them to their normal position. Disinfect the rear and side walls of the upper work surface with alcohol. Place a new waste container in the hood and remove the outer gloves. Dispose of in the new waste container. Clean the outside of the view screen. Deglove and degown properly and log all cleaning and disinfection activities as required in your standard operating procedures. Place all additives, transfer devices, and final containers on a tray near the open end of the hood. Examine each additive for color, clarity, and precipitation. Examine the final containers for cracks, broken seals, or other irregularities. If empty evacuated containers are used, the vacuum must be intact. If the vacuum is not present, discard the container. Now examine the label of each additive. Compare the drug name and concentration to the order. Check the expiration date and transfer the item to the critical work surface. Arrange all working materials at one side of the work zone in a manner that facilitates first air to each critical site. In a horizontal LFCB, working materials should be arranged single file, parallel to, and near the HEPA filter. The final containers may be hung vertically from the IV pole or laid on the work surface in a manner which maintains first air to the additive ports. Remove any flip-off caps and place the caps near the side of the hood on a tray to be used for the collection of compounding debris. The following are examples of improper placement of materials in the LFCB. Materials placed too close together, accumulation of debris with compounding materials, administration ports or other materials blocking first air, and additive ports facing the open end of the hood. In a vertical flow LFCB, or in a biological safety cabinet, the flow of first air comes from above, and a checkerboard pattern may be used provided the operator's hands and arms do not pass over any disinfected items during compounding activities. Remember, hanging items from the IV pole in a vertical flow clean bench or in a BSC places the critical additive port outside the flow of first air. The preferred method is to arrange the final containers on the work surface to assure first air to the critical orifice and improve handling stability. When compounding hazardous materials, be sure everything required to complete the procedure has been staged in the hood. Moving the hands in and out of the hood during compounding can lead to contamination of the environment. Disinfect each critical site with 70% IPA by spraying all critical sites or swabbing each individual site with a fresh alcohol swab. Do not open ampules at this time. While the alcohol is drying, mentally work through the compounding procedure, identifying each item that will be required, such as syringes, dispensing pens, filter needles and straws, syringe caps and tamper seals. This procedure not only ensures that all required tools will be at hand without the need to leave the critical compounding environment, but also helps the operator to plan a smooth compounding process. Remove all wrappers not required for sterility and place all working materials in the hood near the staged vials and final containers. Disinfect gloves and allow them to dry in the laminar airstream. Commence compounding operations following drying of the alcohol. When selecting syringes, be sure the syringe is large enough to accommodate the volume required and allow some leeway for adjusting the final dose and removing bubbles. When compounding hazardous materials, the syringe should never be more than 3/4 full, However, it is desirable to use the smallest syringe possible to increase accuracy. The volume to be drawn up should always be at least 20% of the syringe capacity. All syringes used for compounding hazardous drugs should have Luer-Lock type needle attachments, and dispensing pins for hazardous materials must have hydrophobic filters. The thickness of needles is indicated by the gauge. The higher the gauge number, the smaller the needle diameter. Smaller diameter needles should be used to avoid creating large punctures in the septa, which may not reseal. Also, avoid re-entering the same puncture hole. This increases the hole size and creates leakage and coring. When developing and practicing procedures, an evaluation of risk factors should be made. To the extent possible, minimize the time that any critical site or pathway is exposed. Perform the most difficult manipulations in the process first, if possible, with the least exposure of critical sites and pathways. Validation of pharmacy operations occurs on two levels: technique validation and process validation. Technique validation demonstrates the ability of the operator to perform fundamental core manipulative techniques. Process validation then demonstrates the suitability of the application of these core techniques to a specific compounding process. The core techniques which will be demonstrated include assembling a needle and syringe, drawing liquids from vials, reconstituting powders in vials, drawing liquids from an ampule, use of vented dispensing pins, use of repeating syringes, injecting into final containers, capping of syringes, and connecting tubing. The risk factors when assembling a needle and syringe are 1. Touch contamination of the exposed hub and needle, and 2. Airborne contamination due to disruption of first air to critical sites or pathways. For paper-wrapped needles and syringes with hub covers, aseptically grasp the flaps of the cover and peel them back, folding them down along the sides of the needle with the open needle hub pointed into first air, keeping fingers well away from the exposed hub. Lodge the needle tip securely between the palm and the last 3 fingers. Using the thumb and forefinger of the needle hand, twist the cap off the syringe. Bring the needle and the syringe together in first air and secure the needle to the syringe by twisting gently to activate the lock. Do not block the flow of first air to any critical site during this procedure. For all other packaged systems, first open the syringe, making sure the exposed tip is maintained in first air. Proceed with opening the needle using the thumb and index finger of the syringe hand. Bring the needle and syringe together in first air and secure the needle to the syringe by twisting gently to activate the lock. Risk factors are as follows: 1. Touch contamination. 2. Airborne contamination due to disruption of first air. 3. Contaminant transfer from the surface of the septum. 4. Particulate contamination due to coring. 5. Contamination of the operator and the environment with drug residue. And 6. Inaccurate measurement of drug product leading to incorrect dosing. To draw liquid from a vial, be certain that the vial septum is properly disinfected and the alcohol is allowed to dry. Place the vial so that the first air flows over the septum and exposed needle at all times. Remove the needle cap by pulling straight outward. Aspirate a volume of first air at least 5 mL less than the volume of fluid you intend to remove from the vial. Place the tip of the needle against the septum with the syringe oriented vertically, but do not re-enter an existing puncture hole. Apply slight lateral pressure to bow the needle slightly in the direction opposite the bevel until the beveled angle is perpendicular to the septum, and insert the needle. Once the needle bevel has penetrated the septum, relax the lateral pressure and allow the needle to straighten. Only slight pressure is required to properly orient the bevel so that coring of the septum will not occur. Do not bend or permanently distort the needle during this procedure. Grasp the vial and syringe so that the fingers are not near the septum needle critical junction, and invert the assembly, maintaining the flow of first air across the critical site. Do not block the flow of first air. You may use a V-grip or any other secure grip suited to the container and your hand that maintains the flow of first air to the critical junction. The V-grip is accomplished by wedging the inverted vial between the slightly bent index and middle fingers at the neck and using the remaining fingers to grasp the syringe barrel. This leaves the other hand completely free to manipulate the plunger. For large vials, it may be necessary to grasp the inverted vial by the base and hold the syringe plunger button with the other hand, using the index finger to push against the flanges of the syringe. This technique is used to avoid palming or touching the plunger shaft. When compounding hazardous substances, the added control achieved by grasping the distal portion of the plunger may be necessary for safety and to assure sterility, provided the syringes are not reused and the touched plunger is not allowed to travel into the drug-containing section of the syringe. Do not block the flow of first air. In a vertical flow cabinet, this is best accomplished by holding the assembly so that the vial is slightly higher than, but not directly above, the syringe. In a horizontal flow hood, the vial syringe assembly can be completely inverted and held vertically. When drawing fluid out of the vial, always pull in a slow, steady stream, which minimizes the production of bubbles. Avoid pushing against pressure on a syringe plunger during any vial compounding procedure, and never force air into the vial. Rather, keep the needle below the fluid level and pull back on the plunger, allowing fluid to enter the syringe. When resistance is encountered, release the plunger, allowing air to enter the vial until the pressure is neutralized. Repeat this procedure in a seesaw manner until no air remains in the syringe. Dislodge all air bubbles and clear any air from the hub of the needle. Continue to gently withdraw fluid into the syringe until the required dose is achieved, and the system is now under slight negative pressure. This method is known as low pressure or seesaw technique. Do not remove the needle from the septum until the required dose has been drawn up and all volume adjustments have been made. Remove the vial from the needle rather than the needle from the vial. This will assure better needle control. If seesaw technique is properly used and all final measurements are made prior to withdrawing the vial from the needle, no drug will be released into the environment. Have a pharmacist verify the plunger position and check the vial label against the order prior to injecting drug into the final container. For multiple-use vials, if drug remains in the vial, prepare an ID label, which should contain the date of opening, pharmacy use expiration date, and the initials of the operator on a sticker, and place it on the vial. For reconstituted products, the type and amount of diluent and the final concentration should also be included on the ID label. Reconstituting powders and vials. Risk factors are touch contamination, airborne contamination, contaminant transfer, particulate contamination due to coring, and contamination of the environment and operator. An additional risk is that drug product may not be fully dissolved or distributed in the solution, resulting in the delivery of an incorrect dose. To reconstitute a powder in a vial, be certain the vial septum is disinfected and the alcohol has dried completely. Draw up the required volume of diluent. Have a pharmacist verify the proper diluent and plunger position. Keeping first air over the septum and needle, grasp the base of the vial to secure it. Insert the needle into the vial and pull back on the plunger as far as possible without pulling the plunger past the stop. This creates negative pressure in the vial. For vials which already contain a vacuum, this step is not required. Remember, avoid pushing on the plunger against pressure when compounding with a vial. Allow the diluent to flow into the vial until the pressure is neutral, and in a seesaw fashion, repeat the procedure until all the fluid has been transferred into the vial. If the vial syringe assembly must be shaken periodically to effect complete dissolution, do so gently, keeping the critical site in first air, away from other compounding activities and critical sites. If a dose is to be drawn up immediately following complete dissolution of the drug, invert the assembly and pull back on the plunger, seesawing the compound back into the syringe, and make the final dosage adjustment. Remove the vial slowly from the needle. Drawing liquids from an ampule.
The ampule represents the greatest risk of product contamination during normal compounding procedures for two reasons. First, debris on the neck of the ampule and fragments of glass may easily fall into the ampule, presenting a high contamination risk. Second, the neck of the ampule is a large, open pathway, allowing easy entry of airborne contaminants as soon as the top is removed. For these important reasons, several special rules apply to the use of ampules and must be strictly adhered to.
Risk factors are touch contamination, contaminant transfer, and contamination of the environment or operator. Additional risk factors are particulate contamination with fragments of glass and debris, and an increased risk of airborne contamination due to the large open critical pathway. If drug product remains in the top or neck of the ampule when it is opened, this may lead to contamination of the environment or exposure of the operator. In addition, flying glass fragments may injure the operator or damage the HEPA filter. Shake the ampule with a firm downward stroke to remove any drug from the top. Thoroughly clean and disinfect the neck of the ampule with an alcohol swab. This is a physical cleansing as well as a disinfecting procedure. While the alcohol is drying, prepare the syringe. Holding the ampule in an upright position, grasp the top in one hand, positioning the thumb just above the neck at the widest point of the top. Grasp the bottom of the ampule with the other hand, positioning the thumb just below the neck. Remember, some ampules are specially marked with small dots for proper thumb positioning. If these pressure points are not used, these ampules will not open. Point the ampule toward the side of the hood so that no fragments of glass will fly into the HEPA filter or at the operator. While pulling upward and back on the top, slowly increase the pressure applied by the thumbs until the ampule just pops open. Place the ampule on the work surface, holding the base with one hand. Draw up the contents immediately to minimize exposure to airborne contaminants. Position the syringe in the other hand so that the palm is upward and the needle extends outward from the side of the hand, away from the thumb. Place the thumb under the edge of the plunger button. Tip the ampule slightly and insert the needle carefully into the neck, bevel side down. Push back on the plunger slowly with the thumb as you tilt the ampule farther to keep the needle under the fluid level, until all contents are withdrawn. To avoid pulling up glass fragments or debris, do not push the needle against the bottom of the ampule. Hold the syringe in a vertical position, eliminate any bubbles, and pull back on the plunger button to clear the needle. Change to the filter needle. Carefully refill the needle and make the final dosage adjustment, disposing of any excess carefully, in accordance with policy. It does not matter whether you use the filter needle to draw up the fluid or to inject it into the final solution, except when drawing up a dose in a syringe that will be sent directly to the floor. Otherwise, it is generally easier to push through the filter needle than to pull. When working with hazardous materials and ampules, be sure that all drug is removed from the top and wrap the entire upper portion of the ampule with a sterile gauze pad to contain any splattering drug or glass. Alcohol pads are not recommended for this purpose because the alcohol may cross-contaminate the drug. Use of vented dispensing pins. Risk factors are touch contamination, particulate contamination due to coring, contaminant transfer, and contamination of the environment and operator. Improper handling of the dispensing pin cap may increase the risk of touch contamination. Also, use of a dispensing pin requires extra assembly manipulations. More manipulations present more opportunities for contamination. While dispensing pins do reduce the risk of coring, and use of a pin with a hydrophobic filter can reduce the risk of drug release into the environment, improper technique or use of a hydrophilic pin can increase the risk of drug release. Be certain the vial septum is disinfected and has dried completely. Locate the vial so that the flow of first air over the septum will not be interrupted. Remove the spike cover by pulling straight out and insert the pin into the middle of the septum. If the contents are to be reconstituted, draw up the required volume of diluent in a syringe and recap the needle. Remove the dispensing pin cap aseptically and place it in first air, inside up. Hold the syringe in a near horizontal position and remove the needle. Bring the dispensing pin hub to the syringe attachment and twist to lock syringe to pin. Place the assembly on the work surface and reconstitute as usual. Aseptically remove the syringe and replace the dispensing pin cap. Place an ID label on the vial. When ready to withdraw the drug, remove the cap aseptically and place it in first air, inside up. Remove the hub cover from the syringe and twist it onto the dispensing pin hub. Invert the assembly, keeping the critical sites in first air. Withdraw the required dose. Remove any bubbles and make the final dosage adjustment. Turn the assembly to the horizontal position and carefully twist to unlock the connection between the syringe and dispensing pin, tipping both so that the open orifices are pointing upward as they separate. Set the vial aside in first air and attach a needle or syringe cap to the syringe, as required. Aseptically replace the dispensing pin cap. Please note that dispensing pins may not be appropriate for very small vials. The thick pin may push the vial stopper into the vial rather than puncturing it. Also, not all drug can be removed with a dispensing pin due to the height of the inlet holes. It is not acceptable to wiggle the pin back out in an attempt to extract more of the drug from the vial. Neither should pins be moved from one vial to another. All vial and dispensing pin assemblies should be capped and disposed of intact. Use of repeating syringes. In addition to the risk factors common to the compounding procedures we have discussed, improper adjustment of the repeating syringe or incorrect technique may result in incorrect measurement. There is also an increased risk of cross-contamination if needles are not changed. Remove the repeating syringe from its package and hang it from a hook on the IV pole, or position it on the work surface in first air. If using a bag for the source solution, orient the administration port in first air and remove its plastic cover, using care not to contaminate the sterile pathway. Remove the cap from the spike end of the tubing attached to the syringe and insert it into the administration port, puncturing the inner seal. If a bottle is to be used, remove the metal cover and rubber seal. Hang the bag or bottle. To prime the tubing and fill the syringe, depress the plunger completely and let it retract, holding the needle over a specimen cup or other container. Repeat this action until the tubing and syringe are completely filled, and adjust the syringe to the desired dispensing volume by depressing the plunger the appropriate amount and turning the retaining nut down the threaded shaft to lock the plunger in place. Always assume that the dispensing needle on a hanging repeating syringe is used and replace it prior to use. All dispensing with a repeating syringe should be performed using a vented needle or adapter to prevent buildup of pressure in the vial. To avoid cross-contamination and coring, do not reuse needles. Do not use the same syringe and transfer set to dispense different fluids. When dispensing, always make sure the plunger is completely extended and the barrel of the syringe is full. Dispensing must be accomplished in a single positive injection, because allowing the plunger to retract will cause additional fluid to be added into the syringe, changing the final fluid volume delivered. Place an ID label on the reconstituted vial. Automated compounding devices.
There are several types of compounders in use. The following presentation is an example of one type of compounder. The official operator's manual for the specific compounder should be studied, along with any training literature and films supplied, and a test of proficiency with your specific compounder should be successfully completed prior to using the device.
Automated compounders can reduce the time required to transfer large volumes of solution for complex compounding tasks such as preparation of parenteral nutrition solutions. However, the use of automated compounders presents its own set of risks. Any contamination introduced or errors which affect accuracy may adversely affect multiple patients. Care must also be taken when changing source solutions to maintain first air flow. If data entry is incorrect or mispumping occurs, inaccurate volumes will be transferred. If the wrong source container is attached, the final solution will be incorrect. Clean the compounder and install the tubing in accordance with the manufacturer's instructions. Be certain that each tubing connector is installed in the correct pump location and the tubing is properly seated. Make sure that all spike covers remain firmly in place during these procedures to assure sterility. When the compounder is clean and set up, calibrate in accordance with the manufacturer's instructions. This is essential for accuracy. Because the final bag connection port is often located in a position that does not facilitate flow of first air to this critical orifice, it is imperative that the compounder be properly oriented to maximize first air flow over the connection port. The connection port should be closed whenever a bag is not connected, and the operator must exercise extreme care when attaching and removing all bags and connections. It is also essential that the source bag spikes be kept in first air when changing source bags and bottles. The calibration of the unit should be verified on each shift. To ensure accuracy, verify that the correct solution is attached to each station and that the specific gravity entered is correct. Prior to initiation of compounding, a pharmacist should verify solution identities, concentrations, expiration dates, as well as specific gravity and volumes to be pumped against the order. The operator should note the approximate volume in each source bag prior to starting the pumping procedure, and, upon completion of pumping, verify that the correct volumes were pumped. Following initiation of compounding, the final container must not be disturbed in any way. Compounder source solutions and hanging bottles or bags of diluent should have a sticker attached, listing the date and time of opening and the operator's initials. Injecting additives into a bag with an N-type additive port. Risk factors for this procedure are similar to the compounding procedures previously discussed. Disinfect the additive ports and place each in first air to dry. When injecting into the port, be sure that fingers do not block the first air. Be careful to push the needle straight into the middle of the additive tube. It is very easy to force the needle through the back side of the tube, which will destroy the bag and may cause a painful finger puncture. The needle used to inject the bag must be long enough to puncture any inner seal in the tube portion of the additive port and pass through the tube into the bag so that the additives will mix effectively. Tuberculin or other short needles should not be used for injecting additives, because amounts of the drug may remain in the additive tube, preventing it from mixing with the diluent. Tuberculin syringes are often used to measure and add very small doses to an IV admixture. However, the needle on a tuberculin syringe is not long enough and must be changed prior to drawing up a dose. This is done because the amount of diluent required to fill the new needle may be greater than the amount that was in the small tuberculin needle and may represent a significant portion of the small dose normally drawn up in a tuberculin syringe. Mix well after each addition, both to ensure uniformity of the drug in the container and to prevent any interactions that might occur between additives if they are mixed in concentrated amounts.
It is useful to arrange all bags or bottles to be used in a specific orientation at the start of operations, for example with the additive port facing to the right, and turn or move each one in an exact way after additives have been injected, so that you can always tell which bags have been completed. It is not recommended that more than 4 bags with identical orders be staged at one time. All bags must be for identical orders to avoid errors.
Injecting additives into a bag with a belly port. Risk factors for this procedure are similar to the compounding procedures previously discussed. Bags with the additive port on the face of the bag, known as a belly port, should be carefully sanitized prior to loading into the hood, especially in all areas which remain upstream of the critical site. These bags cannot be maintained in first air when hanging from an IV pole, and must be laid on the work surface in a manner which maximizes first air exposure. Care must be exercised to prevent a puncture of the rear side of the bag when injecting additives. This is accomplished by applying firm pressure on the downstream half of the bag to distend the belly port area, thus keeping the port elevated, preventing the needle from contacting the rear side of the bag. Be sure to mix thoroughly after each addition. Injecting additives into a bottle. Risk factors for this procedure are similar to the compounding procedures previously discussed. Disinfect the stopper of IV bottles and orient them in first air. As with bags, mix thoroughly after each addition. Be certain you do not confuse the vent straw with the additive port on vented bottles. Be sure additives are injected through the proper additive port, usually a triangle or other specific designated area on the main septum. Connecting tubing. Risk factors for this procedure are similar to the compounding procedures previously discussed. When an IV administration set is to be attached in the pharmacy, it should be done prior to the addition of any drugs. Lay the bag laterally in first air. Remove the cover from the administration set and discard. Remove the plastic cover from the sterile administration port, taking care not to touch this port. Key the administration spike in the port and push the spike firmly into the administration port, piercing the inner seal. Hang the bag and carefully unfold the tubing. Aseptically place the delivery end in first air over a specimen cup or other receptacle and remove the cover, setting it aside in first air. Open the flow regulator and any slide clamps and prime the tubing. Close the flow regulator and slide clamps and be sure they are secure. Recap the distal end of the tubing, carefully folding the tubing and secure it. Check that the tubing will not leak by pressing slightly on the bag to generate internal pressure while observing the closure for any leakage. Complete compounding as usual. Preparing syringes. Risk factors for this procedure are similar to the compounding procedures previously discussed. When syringes are to be dispensed directly to the floors, the needle should be removed and replaced with a cap. Push-on caps are often provided in packages of 10, which may be opened to reveal 2 at a time, while maintaining the sterility assurance seal through the remainder of the pack. The cap should be opened and placed in first air, and care should be taken when applying the cap to avoid contaminating the cap adjacent to it. Do not use caps left sitting open in the hood, because you have no way of knowing if they are sterile. Do not use push-on type caps for hazardous materials. Twist-on caps are generally packaged singly, in packets similar to needles. The same technique used in applying a needle should be used to attach this type of cap to the syringe. Labeling and initialing.
Upon completion of compounding, all labels should be applied and initialed by the operator. The date of compounding as well as the solution expiration date should be noted. Any auxiliary labels, such as do not refrigerate, and chemotherapeutic agent warning labels should be attached. The final containers should be visually checked for particulates against both a white and black background. The finished containers and vials should be presented to the pharmacist for the final check, and the pharmacist should also check for particulates. This redundancy will assure the best possible accuracy and surveillance of the product.
Line clearance. Because many drugs may be a hazard to a patient for whom they are not intended, the line clearance is performed to assure that no drug or compounding residues remain in the critical work environment following the completion of compounding activities. Any unused drugs, components, and labels should be removed from the compounding area. Unused components remaining in a BSC where hazardous materials have been compounded must be assumed to be contaminated and cannot be returned to general storage areas. The hood work surfaces should be sanitized with a water-based, low-residuing disinfectant cleaner, followed by a 70% isopropanol or ethanol rinse, which is then allowed to dry. All materials used in compounding hazardous substances must be disposed of as contaminated waste in accordance with state and local regulations. You will encounter many other products and devices in your compounding practice. Try to apply the principles presented in this video when designing new compounding procedures. All new procedures developed should be written, and all personnel should receive training in new techniques.
Good techniques are as hard to break as bad ones, and good aseptic technique must be practiced until it is a habit. When it's applied properly, good aseptic technique is like a well-choreographed dance, with each and every movement carefully planned and executed, with no variation. Your preceptor is there to assist you in learning these techniques. You should remember that your preceptor's comments on your techniques are given to help you become a flawless performer rather than as criticism. The compounding process presents a number of ways of producing unsafe admixtures. One is by introducing contaminants. Another is by introducing an improper drug, which may be either the wrong drug or an expired product which no longer has the correct identity and potency. A third is by introducing the wrong amount of the correct drug. To avoid this error, you must develop your calculation skills.
Performing certain types of mathematical calculations is integral to proper compounding of bulk pharmaceutical products into finished dosage forms in pharmacy. Even when computer systems perform such calculations automatically, the pharmacist must still verify that all calculations were performed correctly.
The main types of calculations required for IV admixture compounding are use of ratios, conversion of units, percentage calculations, administration and drip rates, and dosage and dilution calculations. Many calculations used in IV pharmacy can be expressed as ratios. In a ratio, one quantity is related to another by a division operation, which is indicated by the word per. Two ratios are equivalent if they can be made equal by using an appropriate multiplier. For example, 10 times 60 milliliters per 1 hour is equal to 600 milliliters per 10 hours. When the correct ratio is selected, known data can be substituted in the appropriate spaces and calculations then become simple. To use ratios for problem solving, one known ratio is set up as equal to another ratio containing the unknown information. For example, to answer the question, how many micrograms are equal to 0.06 milligrams, we set up an equation where the how many portion of the question is represented by the letter X. Step 1. Using the known information, set up the equation 1,000 micrograms are related to 1 milligram as X micrograms are related to 0.06 milligrams. Step 2. To isolate the unknown, multiply both sides of the equation by 0.06 milligrams. Step 3. To simplify the equation, cancel the milligrams and 0.06. Step 4. Perform the numeric calculation. Let the ones in the denominators be understood. The answer is 60 micrograms equals X micrograms. Notice that the units of measure are manipulated in exactly the same way as the numbers in an equation. Always carry out the unit of measure calculations. It is an excellent way to verify that the manipulations were performed properly. If the units don't come out the way they should, the answer is probably wrong. Conversion of units. A conversion factor is a special kind of ratio that is equal to 1 and is used to convert units of measure. There are 1,000 micrograms per milligram, which can be written 1,000 micrograms per milligram. It can also be written 1 milligram per 1,000 micrograms. In either case, the expression is equal to 1 and can be inserted into any calculation with micrograms or milligrams, in either order, without changing the value of the calculation. To convert from one unit of measure to another, obtain the conversion factor from a table. Set up an equation containing the known and unknown information and solve for the unknown. Convert 2 1/2 ounces to grams. Because calculations are more easily performed using decimals than other fractions, change the 1/2 to a decimal by dividing 1 by 2. Thus, 2 1/2 becomes 2.5. Next, go to the chart and find that there are 28.35 grams per ounce. Step 1. Set up an equation where X grams represent the unknown. 28.35 grams are related to 1 ounce, as X grams are related to 2.5 ounces. Step 2. Isolate the unknown by multiplying both sides of the equation by 2.5 ounces. Step 3. Simplify by canceling the ounces and the 2.5 on the right side of the equation. Step 4. Perform the calculation. Let the ones be understood. The calculated answer is 70.875 grams equals X grams. However, this answer is not acceptable in the form written. It violates the rule of significant digits, which states that no answer can express a higher degree of accuracy than the least accurate term used in its calculation. The degree of accuracy can be interpreted as the number of decimal places. There is only one decimal place in 2.5 ounces. Therefore, there can only be one decimal place in the final answer. Because the number immediately to the right of the last significant digit, in the 100ths place, is greater than 5, we round up to 70.9 grams. Percentage calculations. We are interested in working with percentages because the concentration of a drug in pharmaceutical preparations is often expressed as a percentage. Percentages are a special kind of decimal fraction with a denominator of 100. In other words, 5% is actually 5/100ths. To convert the fraction 1/16 to a percentage, you must first convert it to a decimal fraction, then multiply by 100 and add a percent sign. 1/16 is equal to 0.0625. This times 100% equals 6.25%. Notice that a percentage can have decimal places in it. Also, moving the decimal 2 places to the right is the same as multiplying by 100. To convert a percentage back to a decimal fraction, divide by 100 and remove the percent sign. There are 3 basic types of percentage expressions used to define the concentration of pharmaceutical preparations. Because solids are more easily weighed than measured volumetrically, for mixtures of solids, percentage means parts by weight of a drug in parts by weight of the mixture. Percent weight in weight, or W over W, equals the number of grams of the substance per 100 grams of the total mixture. Because liquids are more easily measured than weighed, for mixtures of solids and liquids, percentage means parts by weight of a drug in parts by volume of mixture. Percent weight in volume, or W over V, equals the number of grams of the substance per 100 milliliters of mixture. For mixtures of liquids in liquids, percentage means parts by volume of a drug in parts by volume of the mixture. Percent volume in volume, or V over V, equals the number of milliliters in the substance per 100 milliliters of mixture. There are two basic rules for solving percentage calculations. Number one, to perform calculations with percentages, you must first convert them to decimals. Number two, the quantities of the active ingredient and total amounts must always be in the same unit or denomination. Use grams for solids and milliliters for liquids. The fundamental percentage equation can be expressed as percent strength equals amount of active ingredient divided by the total amount of preparation times 100%. Find the amount of the active ingredient when the percentage strength and the total quantity of the mixture are known. How many grams of zinc oxide are there in 120 grams of 20% zinc oxide ointment? Let X represent the how many part of the question. Step 1. Set up the equation by making substitutions into the fundamental percentage equation. 20% equals X grams divided by 120 grams times 100%. Step 2. Simplify by canceling the grams and dividing by 100 and removing the percent sign to change to a decimal. Step 3. Isolate the unknown by multiplying by 120. Step 4. Carry out the calculation. 24 equals X. Similar substitutions can be made to find the total quantity of a mixture when the percent strength and the amount of the active ingredient are known, or the percentage strength when the amount of active ingredient and total volume are known. A 70% alcohol water solution contains 55 milliliters of pure alcohol. What is the total volume of the solution? Step 1. Set up the equation by substitution. 70% equals 55 milliliters divided by X milliliters. Step 2. Isolate the unknown and place it in the numerator. Multiply by X milliliters and divide by 70%. Step 3. Simplify. Divide by 100 and remove the percent sign to convert to a decimal. Step 4. Perform the calculation. Dividing 55 by 0.070 yields the result of 78.57. However, this expression is not the correct answer. There are no decimal places in 55 milliliters, so there cannot be any decimal places in the answer. The last significant digit is the ones place. The numeral to the right of the last significant digit in the answer is 5. When this occurs, we can round up or down. So in this case, we will round down to 78 milliliters.
Drug manufacturers must test product for the correct concentration of each drug component prior to release. Pharmacy does not have this method of ensuring that the correct amount of drug was used. Cross-checking of one another's work and computer-generated information is the final safeguard against potentially lethal errors.
Administration and drip rates are easily calculated using ratios because a rate is a ratio. An administration rate is determined by the equation administration rate equals total volume to be infused divided by infusion time. To find the total length of time an IV solution containing 1,000 milliliters will run if the flow rate is 70 milliliters per hour, substitute into the equation and solve. Step 1. Set up the equation by substitution. 70 milliliters per hour equals 1,000 milliliters per X hours. First, multiply by X hours, then divide by 70 milliliters. X equals 14.3. Applying the rule of significant digits, we round down because the digit immediately to the right of the last significant digit is less than 5. The solution will run for 14 hours. To find the flow rate as drops per minute, convert milliliters per hour to milliliters per minute by dividing 70 milliliters per hour by 60 minutes per hour and making it equal to X milliliters per minute. To simplify the calculations, you may separate multiplication factors. 70 times milliliters per hour divided by 60 times minutes per hour. The expression then becomes 1.11 times milliliters per hour divided by minutes per hour. When dividing by a fraction, invert the fractional denominator and multiply. The hours cancel and the answer is 1.11 milliliters per minute. A common drip rate for a standard administration set is 10 drops per 1 milliliter. For a mini drip administration set, it is 60 drops per milliliter. To convert to drops per minute for a standard set in the last equation, multiply 1.11 milliliters per minute times 10 drops per milliliter. The solution is 11.1 drops per minute, which becomes 11 when the rule of significant digits is applied. Dosage and dilution calculations. Dosage and dilution calculations are solved by setting up one or more equations using ratios. A TPN solution is to deliver 8 milliequivalents of magnesium sulfate per liter, which is supplied as a 50% solution. How many milliliters of solution are required for a 2-liter TPN? Start with an equation using the known information and let X equal the milliliters of solution required. A 50% solution contains 50 grams per 100 milliliters of solution. 8 milliequivalents per 1 liter times 2 liters equals X milliliters times 50 grams per 100 milliliters times 1,000 milligrams per 1 gram. Cancel liters, grams, and milliliters, and divide by 100. Carry out the calculations. Divide by 500 milligrams. Rearranging the factors makes it very clear that we have done something wrong. In order to solve the equation, it looks as though we will need a conversion factor for milliequivalents and milligrams. The equivalent weight of a substance is based upon the molecular weight of the substance and the valence of the ion. Remember, no conversion factor exists for converting equivalent weights, molar concentrations, or normals to conventional measures of weight. To solve this problem, we need to know that each milliliter of the magnesium sulfate contains 4.06 milliequivalents. The problem is then solved as follows. 4.06 milliequivalents per milliliter times X milliliters equals 8 milliequivalents per liter times 2 liters. The answer is 3.94 milliliters. Because there are no decimal places in the expressions involving liters, this is rounded off to 4.
Absolute understanding of these concepts is required to assure accuracy of your calculations.
As an industry person, I can't even imagine end product testing not being performed. It scares me. Without final product testing, if you don't have process control in place or a validation program in place, it scares me. I wouldn't even want to go to the hospital.